This is the wild case of an older lady with no diagnosis of endothelial dystrophy whatsoever. When we initially saw her, we didn't know what she had, but in the meantime, while she was on the waiting list for a cornea, we managed to figure out that what we were seeing was a case of congenital iridoschisis. It's not quite visible with the hooks in, but the 6 o'clock position, which is at the left of the screen, the iris there is very malformed and has non-adherence between the two leaflets of the anterior stroma and the posterior pigment epithelium. And the pupil would not dilate. It would be a pinhole pupil with all of the mydriatics and intracameral mydriatics that we'd used. So we're planning for a Phaco DMEK because the patient has both a cataract and endothelial dystrophy, which is usual with cases of iridoschisis. The other eye is exactly the same, but with much worse visibility. So using hooks, we're going through the phaco part very slowly because you never want to have any complications during cataract surgery, especially if you're also planning for an endothelial graft, because if you want to cancel the endothelial graft, it's usually not possible because the graft is already loaded onto the table and you can't quite put it back, and it has an expiration date that's quite short and you need to call in another patient. This patient was also very hyperopic. The IOL that's going into the bag now is 32 diopters. Luckily, we managed to get it into the bag with no issues. Now we're proceeding with the stripping part, which happens to go very quickly and very smoothly. It's like the decimase almost wants to come off with very little manipulation. So the stripping part is the easy part. We do it, we perform a complete strip, like from Schwalbe's line to Schwalbe's line across the AC. What we also see is that the iris doesn't really want to move back. So we think that we're going to have problems with the final airfill. So here we're loaded the graft into the injector, we're slowly injecting it, and there's no issue at this point. The fact that we've chosen, I believe this is an 8mm graft that looks like is occupying the whole chamber, gives you an idea of what a very small white-to-white this patient has. So we're lucky in the sense that the graft has been smoothly injected and has not rotated during the injection process, and it is still right side up as we had positioned it into the injector. And with short taps on the cornea, we managed to get it centered and unfolded, and then the final airfill is more difficult. The air doesn't want to move all the way out, but we still got a good result. Thanks for watching.